Okay, morning everyone. Really delighted to be here and really delighted that this is the biggest meeting so far. So I think what you said, Marianne. The Sequoia Project plays a very, very special role in the nation's ongoing conversation around health IT and interoperability, and just want to acknowledge that. I know over many, many years, it was my privilege to be on the board for so many years, and definitely want to note and say how much we admire and how much we count on Marianne's leadership, the board's leadership, and everyone who works at the Sequoia Project, and all of you who are active contributors as we think about the call for volunteers for the working groups. As we know, and I think Marianne said this earlier, they can't do what they do without all of you. Thank you from ONC as well for everything that you do, and especially to the Sequoia Project as well for everything that they do. I'm going to do a whirlwind through a bunch of stuff that ONC is working on. And I know the RCE team may not realize, but ONC does like a bunch of other things too. We don't just do TEFCA, even though we're on calls every single day about TEFCA. We actually do a whole bunch of other things. So this is going to be a little bit broader lens for those who were at the Health Exchange meeting yesterday. We talked specifically about TEFCA. I'm going to broaden this to talk about a whole bunch of other things because I know we've got a larger set of things that the Sequoia Project works on. And really I see these slides in the presentation as just being scaffolding or things that can help you formulate questions that you want to talk about. And so I'm going to try to get through the slides as quickly as possible to give you things to sort of look at and see where we are. And really I look forward to the conversation and being able to hear from you, both reactions, praise, we always take praise, and certainly questions. So let me dive in. ONC, I kind of divide it up into sort of two ways of looking at the world. The left-hand side is kind of our key areas of focus in a way of thinking about what's the narrative here? What is it we're trying to accomplish at the end of the day in a way that kind of speaks to our desire, our collective desire to have healthcare interoperability that serves patients at the end of the day. And on the right-hand side is the more wonky view of, all right, and what are all the rules and regulations that we've got in play to be able to help facilitate that, both with ONC as well as our partners. On the left-hand side is a little bit of, sort of table of contents for us to say, we've got 3-4 areas that we focus on. One is continuing to build the digital foundation. We've spent as a country over $35 billion in private and public money, at least an equal amount on the private side, blood, sweat, and tears on the part of providers and others who are implementing electronic health records, to the point that in a relatively short period of time, just over a decade, we went from very little adoption of electronic health records to the point now where 97% of hospitals and over 80% of ambulatory providers across the country have certified electronic health records, certified by ONC. It's a remarkable achievement. And that's sort of the digital floor, right? That's just the first step that we want to be able to accomplish, to say, all right, now we are positioned to do the things in the 21st century that we want to be able to do with a digitally native healthcare ecosystem. And that's the opportunity that we have now as we start to think about that. But we still have gaps. And so we work on data standards to sort of have that minimum data set or a set of data standards. It's kind of the rising floor. We'll talk about that in a second. There are health IT gaps, as we know, behavioral health, LTPAC, different parts of the care continuum that did not get the benefit of the meaningful use dollars. So we're working hard on seeing what we can do within the department to help to fill those gaps. And then second is you provide the digital tools. So we've done a lot of work to do that. And how do we make interoperability easier? How do you make it easier for information to be shared using those tools? So we'll certainly talk about TEFCA and APIs, which is a key focus of saying, how do you just make it easier to take away the friction of being able to share information? Because we know there is friction, and anytime there's any kind of friction, that sort of demotivates anyone from trying to think about interoperability. So how do we make that more and more something that's just easily accessible and easy to do? Promoting information sharing is another part of it. We'll talk about information blocking. As we've found, and as the Congress noted in the 21st Century Cures Act, just because you build it doesn't mean they will come. And so we need to do more to say, well, we've done a lot to provide tools, we've done a lot to provide interoperability, and we're working harder on making interoperability easier, and you need to actually use those things. You need to use those things because patients need it. at the end of the day. Patients need it, and we all know that, and we need to, sort of just push really hard and recognize that as a key priority and move forward on that. And then finally is ensuring responsible use of digital information. So you provided tools, you made interoperability easier, you've encouraged people to do it. What about on the other end? How do we say, well, are there guardrails around this? Do we have concerns about all the information that's being shared? We obviously do. I'll focus on just a couple of things. O&C, obviously, we have limited authority over some of that. But there are some things that we're spending a lot of time on, and I'll spend more time on what we're doing in AI. This wouldn't be a Health IT meeting if we didn't talk about AI. But we have a lot going on in AI, and happy to talk about that, and then certainly happy to dive down in the Q&A. So let's dive in. One thing that I like to just note in almost every meeting I'm in is something that isn't obvious because we've got our rulemaking, and I should just sort of mention, just to give you a sense of the amount of activity that is going on, is that on the right-hand side I sort of showed the different rules. Just to give you an update on those, HTI 1 is the rule that we had a draft rule that we published in March, I think. Got public comments. We're working through all of that. We are working very hard to with OMB to get that final rule out, and hopefully we'll have very much something more to say about that very soon. But working very hard, and that's got a lot of key elements in it that are really important for us. The AI pieces are a key part of that. Data elements to support health equity are a key part of that. But we're working very, very hard on that. Fast on the heels of that, for those who follow the unified agenda, which I'm sure all of you do, which is the schedule of regulations, we do have on there listed HTI 2. Because we want to make sure that there's no rest for the weary. But that would be a second rule. That would be the draft rule that'll follow, that's following closely on the heels. I don't think we're going to hit November. It says November in the unified agenda, but we're working very, very hard to get that draft rule out before the end of the year. That's really important. It's got a really important set of things in it. Some of them related to public health, for example, and I know my colleague and really good friend Jen Layden's going to be speaking right after me, and a number of the CDC team are here as well, and we're working really closely with CDC on a number of things related to public health, and HTI 2 has some of that in it as described in the unified agenda, as well as some other things that are really important. TEFCA, we'll talk about that in a second, and then appropriate disincentives. I know we're going to talk about information blocking, but just to flag for everyone, if you didn't see it, about 2 weeks ago we did release, the department released the appropriate disincentives draft rule, which starts to complete the puzzle on information blocking that was in the 21st Century Cures Act, but has taken us a while to actually get all those pieces into place. So another part of this, which is not something that's generally publicly known because it's not a rule, it doesn't go through notice and comment rulemaking, but I'd just like to point out that within the department, the secretary and the deputy secretary have taken very seriously the policy frame that health IT is an increasingly important part of everything we do in healthcare. And we need to have more formalized processes in the department to align the health IT activities that are going on across the department. And 7 years ago, this wasn't that big a deal, right? Because we didn't have the kind of adoption of electronic health records that we did today. We didn't have the kind of solutions that we had today. We didn't have cloud native kind of solutions that offer scale compute power, scale commodity storage, all of those things that now have come into play. And all of our federal agency partners, and certainly in HHS, have very formalized and active engagement with with electronic health records and health information technology. And so we put into place, Secretary and Deputy Secretary put into place a policy that requires that all those HHS agencies align with the standards that are approved by ONC as it relates to clinical IT and clinical interoperability. And the idea is that we ought to be doing what we're asking all of you to do. I know it's shocking when the government does that, but that's one thing that we believe in HHS that we're actually going to do, which is to say that we're putting into regulation open industry standards, FHIR APIs, all of that, and we're working with our agency partners to say that's what we should be doing internally as well. That's what we should be doing across all of our programs, and saying start with the US CDI, start with FHIR APIs, because that's what the industry is doing, and that'll give better bang for the buck for stakeholders and for taxpayers, and will also give greater synergies across our HHS agencies as well. So I know Jen's going to talk about CDC. That's just an example of the kind of work that we're doing with our agency partners to get that kind of alignment. All right, let me dive down to some of the topics. Data. Let's start with data. You're hopefully familiar with the US CDI. This is the US CDI version 3, which we have proposed in our draft rule be the next certification requirement for support of data. The US CDI is rapidly becoming kind of the minimum data set of the healthcare delivery system, and our agency partners are starting to leverage it as well, which is a really important development, I think, for all of us to be able to move forward with greater alignment in being able to have standardized data and the ability to share information and share data with as little friction as possible. It doesn't solve all the problems. The idea, as I said, is more about a minimum data set, but we're also working on extensions of that for particular use cases, because there was burgeoning demand from some of our agency partners to say, we like the US CDI, we like that it's available across the country, but we have additional needs on top for quality, for public health, for UDS reporting. So we launched this program, the US CDI Plus program. It is not a streaming service. It is a very specific set of programs that we work with our agency partners to extend from the US CDI to serve their needs, but also make sure that it's tethered in data elements that the providers are required to support and payers are required to support in their own systems. And that way it gives us greater alignment, gives you better ability to be able to work with those federal agency partners as you're working with them. So we've got very active work going on with CMS on quality, US CDI Plus for quality. Jen, I think we'll talk about US CDI Plus for public health and the work we're doing with CDC. And HRSA is launching, I think in January, UDS Plus reporting, as they call it, which is an extension of the US CDI, but it's also FHIR-enabled. So doing FHIR-enabled reporting to HRSA for UDS reporting from federally qualified health centers, which is fantastic. We're really excited about that. And we worked with them on building that FHIR server that they've got in place now to receive those. And then finally, we are launching now a US CDI Plus for Cancer initiative in partnership with NCI, the FDA, and the White House Cancer Moonshot team. So we're really excited about that as well. But just to give you a flavor of the work that we're doing to keep us moving forward with data, keep us sort of agile and serving particular use cases, but also having that US CDI general sort of construct as being the rising floor of that minimum data set that all of us can count on. FHIR APIs, I told you this is going to be a whirlwind. FHIR APIs, all of you are familiar with FHIR, hopefully all of you are familiar with FHIR APIs. The requirement that I just like to remind people of, because there's varying degrees of awareness of this, is that we actually are at a pivotal moment as it relates to deployment of FHIR APIs. I mean, FHIR APIs have been around, obviously, for 4 or 5 years. A number of vendors and others, Apple Health Record, others leapt out ahead and actually implemented, FHIR APIs in their systems, which is fantastic. But the regulatory requirement didn't actually fully come into place until December 31st, 2022, because it was at that point that all certified EHR vendors were required to make available to their customers a standard FHIR API that would allow an external party that's authorized to get that information to be able to get that information through a FHIR API. So that's, sort of, again, the regulatory process works, sort of methodically, but that's a threshold moment because that means that all those organizations then were required to make that available. And then CMS rules kind of followed and said that in their payment rules for providers who participate in a number of CMS payment programs, they were required as of October 1st to have that version of their EHR in place. So working together with CMS and ONC, we're now in a position to say, over the next year, we're going to have this FHIR foundation, this FHIR API foundation that covers, as I said, 97% of hospitals, 80% of ambulatory practices, which is just that foundation that will allow us to, sort of have much more rapid acceleration, I think, of innovation. There is certainly friction. There are things that we're discovering, on an ongoing basis. Where's Jenny Blumenthal? Is she here? Hey, Jenny, just thought I'd call you out. How's everything going? Cool, cool, cool. Okay, yeah. So, inside joke. So one of the things that we're doing is that we have a program called Lantern. And with Lantern, we're actually basically going and pinging all those endpoints that are required to be made available. And so ONC regs require that EHR vendors publish their endpoints that they're required to make available on the ONC website. So we actually can go and find those and we can ping them. And so we are on a near real-time basis, we just ping those APIs. Is it there? It's supposed to be there. And then what's in the capability statement? What services does that API actually serve? right? And that's all a part of the FHIR specification. So we're going to be doing more and more of that because what we want to be able to do is say, let's offer this, this information to the market. ONC knows who's certified their APIs, but we don't know who's actually implemented them. This is a way for us to get at that. The other part of this, for payers in the room, we're going to start looking for payer APIs as well. CMS requires that payers make available member-facing APIs, and in their draft rule, they require a new set of APIs, which we think are fantastic. There hasn't been as much visibility around those. There was no requirements to publish those those endpoints. So if you're a payer here, we're coming after you with Lantern. We're going to try to find that API and make the data publicly available on whether you've got that, because we think that provides information to patients, information to the market to help the market move forward. And that's a critical role for the federal government, I think. The other thing I like to just sort of point out, and I'll just sort of flash this on the screen, happy to dive into more detail, is that we in the federal government are doing a lot to deploy FHIR APIs, to going back to that principle of we want to make actions that sort of show that we're model citizens to help encourage the industry to move forward with the kinds of things that we'd like to be able to have the industry support as well. So we start with all the way in the bottom here, the ONC requirement for a FHIR API, as I said, in certified health IT systems. And then that starts to branch out to CMS requiring that providers have that version of the software available in their systems as of October 1st. It is CMS actually deploying their own APIs for their own information, the beneficiary information, and my favorite, the DPC, the data at the point of care pilot, where CMS makes available via a FHIR API fee-for-service claims data, so a provider can access that and get all of their claims data, regardless of whether they submitted that claim, which is huge for continuity of care. Jumping forward, they are now proposing to make that a requirement on regulated payers, regulated commercial payers, so that they have to make the same kind of API available. We'll come back to this as we talk about TEFCA. But they've also proposed in regulation a number of other APIs, a payer-to-payer API, as well as a prior auth API. So you can start to see that starts to branch out and have a full portfolio of FHIR APIs that hopefully helps encourage the market to deploy standards-based APIs if they want to do the kinds of transactions that we're talking about here. CDC, and again, I don't want to steal Jen's thunder, CDC has also been doing tremendous work, and we've been working in partnership with them on thinking about FHIR use cases that can help us attack sort of novel problems in public health, one of which is situational awareness data. The other is how do we get IAS access in a more uniform way across all jurisdictions. A bulk FHIR API that allows an authorized user to be able to get vaccination information on a roster of patients, which is a big deal during the pandemic, obviously, where payers, for example, were trying to encourage people to get vaccinated, but they didn't know who was vaccinated and had a really hard time working jurisdiction by jurisdiction to be able to get the information that they were authorized to get. So we're working really hard on saying, how do we use FHIR to be able to creatively help solve that? TEFCA, the moment you've been waiting for, maybe. TEFCA, we are, let me just say before I start on TEFCA, we are, just couldn't be happier with the relationship we have with the RCE. And, at the risk of missing people, Marianne, Alan Swenson, Zoe Barber, Chantal, Aaron, I know I'm going to miss someone, Dave Pike, and a number of other people. I didn't name you. That is not for lack of appreciation of everything you're doing. We've been working really hard with the RCE team, rolling up our sleeves and getting us to a really critical point and a really exciting point that I'll just describe here in a second. And that was hard. It was an intense effort in a relatively short period of time. I think Michael had mentioned, my being on the Sequoia board, which was a great experience, and I was, really privileged to be able to do that. One of the implications of that was that when I took the job in January of 2021, I was conflicted out of being able to work on anything that the Sequoia project was working on. It was like, you gotta be kidding me. One of our significant initiatives from ONC, and I literally for 6 months, I think it was 5 or 6 months, was not allowed to talk to the team, know anything about what was going on with TEFCA. I couldn't talk to Marianne about it, nothing, as we worked through the government ethics process, and we're finally able to get that cleared. So we had a little bit of a stall in terms of this administration coming in and being able to put our own fingerprint or our own perspective on TEFCA. But then once we started in the summer of 2021, there's just fantastic, as Marianne said, ONC and the RCE working really as one team. which I think is the way that all of us want to be able to do these things. So we're able to really do this as a joint team to be able to get us to the point that we are today, which is a really exciting point. As I think all of you may know, there are 6 approved exchange purposes, and we are working to start to think about what's use case number 7, or what's exchange purpose number 7, which may be authorized use cases, which is say where a patient authorization is required. Research is obviously a big one there, and our FDA and NIH partners are very interested, as you can imagine, in thinking about how we might be able to leverage TEFCA in the future to be able to support those research needs where patient authorization is required. And you also have de-identification issues, obviously, that make it a little bit more complex. So the reason you don't see that on this list is not because it's not important, it's just because there's an additional layer of complexity that we know exists with that. And when we've got talking to the Vulcan community, the Vulcan Fire Accelerator, as well as others to say, how do we do that? But these use cases are the ones front and center that we want to be able to implement as soon as we can. Where are we? Well, at the beginning of this calendar year, in February, we were able to announce and had the privilege of announcing 6 organizations that had been approved from an eligibility perspective to get the green light to be able to implement TEFCA and get their designation status where they could go live. We've since added a 7th, MedAllies, since that time, and we're really excited about where we are in that. All of those organizations working really hard to say, how do we go live with TEFCA before the end of the calendar year? So that was in February of 2023. We had a great event with Secretary Becerra and the President's Science Advisor, Dr. Prabhakar, to be able to make that announcement. And we're now at the point that we're going to be announcing on December 14th at the ONC annual meeting, the go live of TEFCA with a number of QHINs that are going to be live, essentially. They will be countersigning the common agreement, and they will have their certs in place, and that means that they are able to transact at that point, which is a huge moment. And a testament to the RCE, testament to the ONC team, to be able to get us to this point. And that marks, I think, as all of you may appreciate, the end of the beginning. Which is a tremendous amount of work, but it is the end of the beginning. Because that just begins, sort of the first part, which is the IHE document exchange framework. But as we know, FHIR is hugely important to this administration and to everything that we're doing. I personally invested a lot of time in, working with FHIR as well. And we've pushed really hard to say, TEFCA is the way for us to be able to support FHIR scalability in the ways that all of us want to be able to, to have that. And so we're also working very hard to get the next version of the common agreement in place for adoption by all of the QHINs, all of the approved QHINs at that point, by the end of the first quarter of 2024, so that we can go live with FHIR Exchange in 2024. And there's a couple of reasons that's really important. The one big reason that it's really important is that I think that that's what we need for FHIR scalability. For those who participated in the FAST initiative, that ONC sponsored and then it moved to a FHIR accelerator, and that was a group of providers, payers, others who were pointing out FHIR APIs are great, but if we don't have some kind of network structure for scalability, it's really difficult for us to be able to scale that. If I have to figure out on my own all of the endpoints, the electronic endpoints for every endpoint that I want to be able to hit with my FHIR API, if I have to do a security handshake with every single one of those, if I have to do a separate data use agreement with every one of those, if I have to figure out where the patients are to the extent that I'm authorized to be able to do that kind of search on my own, that's really challenging, and it's going to be a real wet blanket on FHIR adoption, as exciting as it is that organizations are being pushed to adopt FHIR APIs. TEFCA offers the solution, those network services, the trust services to be able to allow that providing services to patients who are my members, the ability to just say, I know where the patients are, what are the electronic endpoints of those? Being able to get the electronic endpoints from the endpoint directory that TEFCA provides, being able to leverage the certs that all TEFCA participants are required to have, so I don't have to worry about security. I also know that everyone has signed the common agreement, so I don't have to go through a data use agreement dance. I can just fire off my APIs the way God intended and be able to get back the information that I'm authorized to get, and vice versa. right? And providers being able to do that, going the other way. A critical part of the FHIR APIs, and this gets leads to the second point of the importance of FHIR in TEFCA, is that it is the key to solving some really vexing use cases that we've struggled with in interoperability for a number of years. First is individual access. We don't have the ability, even in the nationwide networks, to be able to get the kind of individual access that we want, right? That dream of a patient just being able to say, I have one app, I have one credential, I can now just query and get all of my records through a single thing, not having to figure out what are all the different portals and being able to, having to do that one channel at a time. The barrier to being able to do that is the kind of end-to-end kind of compliance that we need to be able to have from a HIPAA perspective, from a security perspective. FHIR OAuth is the key to key to unlocking that dilemma. So from our perspective, that's one of the reasons that we think FHIR is really important, to be able to get us to that place where we can do FHIR OAuth kinds of transactions and those patterns, to then fully enable patients to be able to get access to their information using network services. The second key important use case in that area is payers. We haven't had the ability to have payers really participate fully in these nationwide networks, in part because of the jockeying between payers and providers. And a key to breaking that that sort of trust issue is to be able to say, if payers make available claims data to providers, then providers have greater sense that, all right, I'm getting something in return for making my patient's information available, to payers, which has always been a roadblock. But if you look at the APIs that CMS is requiring in the interoperability rule, what we're working on is an approach that says, if a payer implements the provider access API as called for in the CMS interoperability rule and makes that available in TEFCA, we can then set up the framework that says that payers and provider would be required to respond to a payer query, and a payer in turn would be required to respond to a provider query for them to be able to get all of their claims data. So now you have both parties feeling like, all right, I have access to the information that HIPAA authorizes me to have access to, and now we can just have the best available information to be able to do the best on behalf of patients. So that's the other reason that FHIR is critically important, why we're pushing really hard on it. So very much look forward to seeing all of you at the ONC annual meeting, where we'll be able to celebrate this moment, and we're really excited about it. Let me talk about information blocking, and I do want to get off these slides so I can sort of talk to all of you. Just a couple of key points on information blocking. All of you are familiar, I think, generally, hopefully, with the construct of information blocking. One of the challenges, and we had some puzzle pieces that needed to get put into place so that we have a full sense that, all right, information blocking is now the law of the land, right? It's now fully in place, because you had the 21st Century Cures Act in 2016, but you had a whole bunch of pieces, like enforcement wasn't fully in place. OIG had not finalized their rule. They since have finalized their rule so that they're beginning enforcement as of September 1st. But they were not, but the other piece was the penalties that could be assessed on providers who are key actors in the information blocking sort of paradigm, who did not have penalties defined. And OIG in their rule were specific about, we're not going to do investigations on providers if there are no penalties defined. So we need to wait for the penalty to be defined, and then they will become a part of the OIG enforcement mechanism. As we know, enforcement's really important. So we did work really hard, 2.5 years, on getting this appropriate disincentives draft rule out. It's a department rule. It's not an ONC rule. We were just the ones who were the lead authors, as the secretary asked us to do. But take a good look at that. The comment period is open now, but we're really excited that we're now able to at least fill that part of the puzzle. An important thing that I would also note in that rule, and if you look at the press release and the secretary's statement in the press release, was the important part of the appropriate disincentives rule is that it establishes a regulatory framework. Because we started from scratch when we came into this administration. There'd really been nothing done. So we had to establish a regulatory framework and then identify the first set of appropriate disincentives. But the secretary was clear that this sets up a framework for future disincentives as well. So we're now in a course now to say, all right, we can fill out the remaining puzzle piece. And if you look at the data that we have on appropriate disincentives, the appropriate disincentives, we get roughly one complaint per year. One complaint per day, roughly. It's like 5 to 7 complaints per week. Still, the vast majority of those are patients making complaints against providers as it relates to information blocking. So that speaks to the importance of saying we need that enforcement in place, because at least with the data right now, that's where they're saying is sort of a key part of information blocking and what the Congress was trying to solve here. So let me just talk about AI, and then I'm going to stop. AI. ONC has draft regulations in HTI-1 that relates to the use of AI-enabled tools, or the availability, I should say, of AI-enabled tools in certified health IT systems. And where that fits in to the, the overall regulatory approach of the Department of Health and Human Services and healthcare is that it complements what some of our agency partners are doing. So we work very closely with OCR, that in Section 1557 they have made clear that, which is about non-discrimination, that they've made clear that non-discrimination applies to the use of AI-enabled tools as well, right? I mean, they just wanted to make that clear so that everyone knows that you as a provider, you as anyone coming under Section 1557, you have the same obligations with AI-enabled tools as you do with everything else, which is to not discriminate as per the law. FDA, I think, as all of you know, FDA has longstanding authorities related to approval for safety and effectiveness of medical devices and software as a medical device, which encompasses AI-enabled tools. They've approved over 700 AI-enabled tools to date. But that's really about those kinds of tools that qualify for being a medical device, which is a narrow part of the spectrum, and I would argue an increasingly narrow part of the spectrum, and also only those that are being marketed commercially. So if you think about where AI is headed, there are a lot of provider organizations that are developing their own AI-based tools. They wouldn't even fall under that category, right? So you've got a whole growing set of AI-enabled tools that are really falling outside of those existing regulatory frameworks. So the ONC approach is really focused on transparency. What we're going after is to say, increasingly, we want these AI-enabled tools to be made available to providers, to be made available to patients. I mean, patients will have access to things that they have access in general, but we want them to be made available to providers, but we want providers to have as much information as they can have to make judgments about whether that particular tool is appropriate to their particular care setting. And so it's really a focus on transparency. We're not proposing that ONC would approve or evaluate any AI-enabled tool. What we're saying is that if you're a certified health IT vendor, you have the obligation to create functionality to represent what AI-enabled tools are in your system, embedded in your system, because it's not always obvious to a user of an EHR. And there's an obligation to make available information on 14 different types of data that you can think of as the model card for those who are familiar with AI. The nutrition label is the colloquial idea of what's a way to characterize this AI-enabled tool. Where was the data trained? Well, when was it created? And who created it? And what was the training data set that was used? What were the characteristics of that patient population? As John Homka likes to say, Mayo Clinic has fantastic AI-enabled tools that were trained on 1 million blonde Lutherans in Rochester, Minnesota. And now here I am in San Juan, Puerto Rico, and thinking, does that matter? Doesn't it matter? Our view is you need to make that information available for the clinicians, for the hospital to make their determination, as they do every single day, right? Providers make these kind of decisions every single day. Let's remove the black boxness from that and make that available to them. So that's a draft rule right now. We're taking comments. We're working hard on finalizing. And we think that'll be an important contributor that, again, will focus on transparency, is not focused on trying to evaluate or say this tool is good, this tool is bad, but provide a little bit more information to providers for them to be able to make the assessments of whether that tool is appropriate to their particular care setting. And these are the data elements that we are proposing be made available as a part of that nutrition label. So I'm going to stop here because I think I still have 7 minutes anyway. Is that right, Tina? And would love to be able to get your questions, comments, thoughts, feedback. And I'll be here the rest of the day too, so happy to continue the conversation. Thank you. Yep.
Thanks. Michael Saito from Epic. You talked about promoting more API adoption by payer organizations. And obviously, there's a little bit of an asymmetry between what payers support and what providers support and the certification requirements for provider software versus payer software. So I'm wondering whether you see a role for ONC in certification of payer APIs, or whether that's something that you see Sequoia project being able to play a role in, especially as payers start to join TEFCA and TEFCA starts to support FHIR. Wondering what your thoughts are on that.
Yeah, no, it's a great question. So we're definitely looking at that. I mean, we're sort of thinking hard about that as we think about working with CMS, obviously, on their API strategy with the interoperability rule, and we work very closely with them. So it's definitely something that we're sort of looking at, which is basically the general construct of how do we get more of sort of that standards-based interoperability. And it is, to your point, it is a little bit hard when you've got sort of one side of the equation having, so hard requirements related to certification and a little bit more optionality and looseness on the other side. We're also looking at that in public health. So I think that's a part of what we have said in the Unified Agenda. We're working with the CDC team on thinking about, is there a certification approach for public health IT systems as well? Because as a number of people have pointed out to us, we certify the pitchers but not the catchers. And so that creates, sort of a mismatch between saying, well, I can do my public health reporting via standards-based ways because ONC and CDC say that you have to do it that way, but then you've got 64 primary jurisdictions and hundreds of, jurisdictions under them that each of them has their own little spin on that. And so vendors like Epic are having to do it, 64 at least different ways. So we are generally looking at that on the payer side as well as on the public health side for sure. I don't know who's deciding. Yep.
I'm over here on your right. I'm Matt Eisenberg, Stanford Healthcare. Great to see you.
Yep.
Pleasure. So my question is about decision support oversight. So first I'll start by saying it's going to be a brave new world of artificial intelligence to both automate and augment the physician world. So we're very excited about that. But I'm sure you got a ton of comments about the ONC rule. And the one thing that was chilling is I don't know if that's really going to get down to sort of every order set we have in our system and every best practice alert is going to have sort of like a, how many calories is it? Because our decision support committee would have to meet, every day for the rest of their lives. So that's kind of a chilling concern for us. And I'm wondering if you could give us a little insight on where you're really going with that and to what level, that's going to impact us.
Sure, yeah. Well, they don't have anything better to do they?
No, we're just hanging out.
Right.
Yeah. We like to make pop-ups for people. They love that.
Yeah. I mean, we've tried to be clear, and we can, certainly improve upon that clarity. And a lot of feedback we got, I think, was, if you can look at the public comments, we got a lot of feedback that was based on kind of where is the definition here. There were a lot of commenters like, we agree generally, but where are you drawing the line? If you got a whole spectrum of tools, and one part of that spectrum is predictive decision support initiative, interventions that would, sort of have AI-enabled tools. To your point, that that's a part of a spectrum, and where do you draw that line? What we've tried to do is say that there is a line here which is about systems that train or learn from a patient population, from actual experience from data, and then make inferences or predictions or categorizations from that. But that would constitute that definition of predictive decision support interventions. Everything else, things that are like hardwired, rules-based, I am just creating a, sort of an algorithm that just implements a clinical guideline, for example, totally rules-based. We basically say that doesn't fall into this category. Those are things that will continue to exist, do not fall into that category. But then those that then start to get into this area of making inferences from data that is learned, that's what we start to say. That's where you'd have to represent that, because that's where the context of where it actually learned and what it's then predicting is really important at that point. So I'm sure that we'll mature over time as we sort of see how that gets operationalized. So all of us will continue to learn on that. I don't know, am I allowed to call on people?
I'm here. I have a mic.
Oh, okay. And there's someone up here as well after. Yep.
Hey, Mickey, look to your left.
Okay. Hey. Jenny, you're here.
Follow-up question to what Michael just asked from Epic. So we are almost to the end of the year with all of the G10 certified FHIR APIs. We're 2 years past the CMS APIs for patient access, and most of them are not production ready. Most people certified and they're not operational. So how are you thinking about certification going forward? Because they're ONC certified, but they're not ready for production. And we can't build fire at scale without production-ready APIs.
Yeah. So I think that gets a little bit at what I was describing before, and I mean, feedback from you, Jenny, and others who are actually out there trying to implement that stuff is just invaluable, and I can't sort of overstate how invaluable that is, because for ONC this is kind of a new dimension of sort of the regulatory impact and how we need to think about it, because we've focused on certification, and we know that like 96% of vendors, of certified vendors, did get their API certified. But to your point, there's a gap between that certification and what people are experiencing on the ground with respect to how those are being implemented. And there's also a lot of different interpretations, let me call them, of information blocking and how that affects access to, to the APIs as well. So we're using Lantern to try to get a better perspective on what's going on in the market, but it's really, the feedback from those on the ground who we can talk to and deeply engage with that helps inform, are there additional things that we need to do from a regulatory perspective? Are there different things that we need to do from a bully pulpit perspective? All of the above. So I don't have a clean, crisp answer, except that we're looking really closely at it, and we value all of the input that we get to help inform what we ought to do next. Because we know that there is an issue. I will, again, just going back to point out, it is still less than 12 months from when the rule went fully into effect. I know, a number of people have been working with APIs for a number of years, but the rule did fully go into effect at the end of, the last calendar year. So we've kind of got that as well. Yep.
Hello. This is Dr. Chiranjeevi, orthopedic surgeon from India.
And I guess, is this the last question, Tina? Okay, last question.
Yeah. I would like to know ONC cooperation with organizations from other countries, like especially government organizations, the one like NHA in India and NHS in UK, where in future the vaccination certificates, interoperability between critical medical emergency health profile data.
Yep.
How much of mandatoriness can ONC looking forward in implementation of such kind of emergency healthcare data interoperability?
Right. Well, just let me make clear, ONC has no ability to mandate anything in India. But we work very closely. The primary lever for us to do, the global work. I mean, we're doing a lot of work on the International Patient Summary through HL7 and through, global standards development organizations, and the GDHP, the Global Digital Health Partnership, which we chair, I think, to the end of this calendar year. So Steve Posnack, Deputy National Coordinator, is the chair of the GDHP. India was the chair actually in the previous year, so we've worked very closely with India. But in general, that's where we try to drive and help facilitate global conversations, nation-to-nation conversations about standards and about alignment of standards. So I think we'll continue to do that. Holland is the next chair. We've always worked very closely with them as well. So we're looking forward to continuing to do that. So I am around all afternoon. Would love to talk to any of you who are available. And thank you very much again. And thank you for everything you're doing.